All right. Hello, everybody. Welcome. Thanks. It helps always to register for things. I just realized right now. It'd be nice if I had registered myself. So anyway, but we're here. Thank you all. And it is nice to have folks joining. We're just getting more folks in right now. And all right, but why don't we we'll get going because we have a great agenda today, wonderful speakers. Yeah, this is super exciting. So first off, my name is David Mineta. I'm the president and CEO of Momentum for Health. As I said earlier, it would be nice if I had registered myself, so I would have the Zoom link. But anyway, I did it right now. We want to focus on really the speakers and the important topic at hand on eating disorders and behavioral health. So I would like to start there and focus on that. But before we do, I'd like to say a little bit about one of our partner in this, in today's discussion, is another nonprofit that has recovery at its core, and that is the Eating Disorder Resource Center. And for many folks in the South Bay and the Bay Area who have received help from the Eating Disorder Resource Center, they know that this is a nonprofit that promotes awareness, recovery, and advocacy around eating disorders. And I'd like to take just a second to recognize EDRC Executive Director Janice Bremis for her years of service and advocacy on eating disorders. She has helped so many families, so many people in the Bay Area. And in my nearly 8 years at Momentum, I think first of Janice regionally as our subject matter expert on eating disorders. Also, I'd like to thank her colleague, Kanika Kansara, for her help, because Janice, Kanika, and also I want to thank my colleague, Cassia Carter from Momentum, for all the hard work of putting this together today. And so today we're partnering with EDRC and the Stanford School of Medicine to bring you this informational webinar on eating disorders and their connection to behavioral health. As one of the leading providers of behavioral services in Santa Clara County, it's critical that we talk about eating disorders and how they should be considered serious and treatable mental health conditions. It's time to talk about how eating disorders do not just affect adolescents, but in fact, many adults of all ethnic and socioeconomic backgrounds struggle with anorexia, bulimia, and binge eating. It's time to talk about how 27 million people with diagnosed eating disorders in the United States never access treatment. It's way past time to talk about how eating disorders are the second deadliest of all mental illnesses, second only to opioid overdoses, and are perpetuated by mainstream beauty ideals. It's way past time to talk about how someone dies from an eating disorder every 52 seconds. Today, we're here to talk about how we can come together and better support our families, friends, and community members who may be experiencing eating disorders. And as I said earlier, we are joined by an exceptional panel of speakers. Joining us today is Dr. Danielle Colborn of the Stanford School of Medicine, Amia Nash, a doctoral student, UC Berkeley School of Public Health, and a survivor of eating disorder, and Paraag Marathe, president of the 49ers and Enterprises and executive vice president of football operations. So thank you all for being with us today. And the excitement and the number of folks we had register for this, which is sort of an all-time high for us, I think speaks to this stellar panel and speakers we have here today. So over the next hour, each of our panelists will share their experiences and expertise with you. At the end, time permitting, you'll have a chance to ask questions in the Q&A section of the chat. And we would kindly request that you save all your questions for the end. Write them down, but then just save them for the chat at the end. But to kick us off right now, we have Dr. Danielle Colborn, PhD of the Stanford School of Medicine. Dr. Colborn is a clinical assistant professor in the Department of Child and Adolescent Psychiatry Eating Disorder Program at Stanford, where she has conducted research on neurophysiological functioning and weight restoration in adolescents with anorexia, the influence of interpersonal relationships on women with anorexia, and much, much more. And before I turn it over, I'd like to say one last thing about Dr. Colborn. She is also a registered yoga teacher. That is pretty awesome. All that and a registered yoga teacher is pretty cool. So welcome, Dr. Colborn.
Yeah, thank you, David. Really appreciate that. And I just want to say a big thank you to Momentum and to EDRC for organizing this event and creating the opportunity to be here to speak with everyone and to be with these other panelists. I'm just really grateful for this opportunity. So I'm going to go ahead and share my slides. My task here is just to present some background for everyone on eating disorders, what we know about the illnesses, about treatment, about the barriers to treatment, and then a little bit about what you can do if there is someone that you are concerned about, whether you are a provider and it's a client or it's a friend or family member, how you might approach this sensitive but really, really important topic. And there we go. Okay. So just a quick overview. I'm going to talk a bit about eating disorders, a little bit about treatment considerations. I'm not going to go too into depth about the different treatments themselves, but just going to highlight the evidence-based practices that we have, again, and then what to look for in some resources. So I often find it helpful to start out a discussion of eating disorders about talking about what they are not. There are a lot of misconceptions in our society and culture about what eating disorders are. And eating disorders are not about tension or vanity. They are very serious psychiatric illnesses and a sign that someone is needing help coping with something at this time in their lives. They are not just a teenage thing. Not only are they not just normal or typical for adolescents, they do not just affect teens. We see eating disorders across ages in unfortunately very young children and in adults and in even elderly individuals. Eating disorders are not a choice. This is not something that someone is choosing to do to harm themselves or to cause distress to their loved ones. It is something that they are struggling with. It is an illness and one that requires specialized treatment and intervention. Eating disorders are also not limited to one racial or socioeconomic group. There has long time been this stereotype that they only affect upper middle class white teenagers, and we know that that is just absolutely false. They do not discriminate and affect individuals across race, age, socioeconomic background, gender identity, sexual orientation. But as we're going to see, that being a member of a minority group actually presents an additional barrier to accessing treatment. So what are eating disorders? They are severe and persistent abnormal patterns of eating that cause serious disturbance to one's physical and psychological well-being. They not only involve behaviors around food and a preoccupation with shape and weight, but they also involve very distressing emotions and thoughts and a distortion in how one's shape or weight is perceived. Some of the common behaviors we see in disordered eating include severe restriction, binge eating, vomiting, laxative abuse, avoiding specific foods or entire categories of foods, and compulsive and driven exercise. We also know that eating disorders are incredibly dangerous. They are the highest mortality rate of any mental illness. I just heard Dave share a stat on that opioid addiction may be surpassing that. That is not because we have seen a decrease in the rates of mortality from eating disorders, but I think only speaks to the growing epidemic around opioid abuse. This sounds a bit astounding, but every 62 minutes, someone dies as a direct result of an eating disorder. And this is a combination of factors. Individuals with eating disorders have an elevated risk of suicide because of the distressing psychiatric nature of the illnesses. And that is then combined with very severe medical complications that include just a few things I have here: cardiac abnormalities, cardiac arrest, osteoporosis, brain damage, higher risk of fainting, higher risk of falls. It is the physical medical complications combined with the psychiatric piece make these very, unfortunately, very lethal. As also I've noted, there's just a staggering high number of Americans who will suffer from an eating disorder at a given point in their life. Also mentioned, I just want to go a little bit more that eating disorders do not discriminate. They are increasing across demographics. We are seeing an incredibly high number in our inpatient unit of boys coming into our program, of people from minority groups, particularly Latin American individuals. It is an unfortunate thing that eating disorders do not discriminate, and they can really affect anyone. And it is even more problematic that we have data showing that individuals from minority groups are less likely to be assessed by their physicians when they present for care, even though they are presenting signs and symptoms of eating disorders. They're less likely to begin referrals for eating disorder treatment, and they are less likely to seek help for eating disorder care. So when we talk about the lack of treatment seeking or lack of connecting individuals to treatments, when you're a member of a minority group, that is compounded even more. The good news is that eating disorders are treatable. We have evidence-based practices that show that people do recover. What we know is that the earlier we can intervene, the better people's chances of recovery. There is a lot of data showing that with anorexia, for example, when individuals reach kind of the 3 to 5 year mark, the chances of recovery drastically drop. So we don't want to wait. We don't want to hold off. We don't want to see if this happens to people. We want to intervene as soon as we can. We want to get people connected to specialized treatment. That is really, really essential. This is something that is not something that can be treated with just sort of therapy as is, or typical or generalized therapy. It really needs specialized treatment, and it needs treatment from a comprehensive care team most of the time. That includes psychotherapy, medical support, and nutritional support. There are a lot of reasons why people don't seek help for eating disorders. A large part of it is the shame and stigma that go with these illnesses. I have had patients who have presented with not only disordered eating, but a number of the comorbid issues that can sometimes co-occur with eating disorders: anxiety, depression, self-harm, PTSD, other addictions. And I have had patients show complete willingness to talk about a whole host of things that we might expect people would be more reluctant to discuss. But when it comes to talking about their eating disorder, they just shy away from it. They feel that they've done something wrong, that it is their choice, that they are, not going to be understood. And so it's so important that we have events like this to help just spread knowledge and awareness of these illnesses and what they really are. There's also a serious discrepancy in funding for eating disorder treatment and research compared to a number of the other psychiatric illnesses that we see. And so we're really hoping to continue to make changes in that. Just one more time, we know that very low rates of people seek treatment. Some data suggests that 1 in every 10 people struggling with an eating disorder will actually receive treatment. Again, despite the fact that we have treatments that work. So I'm going to talk a little bit about the most common eating disorders that we tend to see presenting in our clinics. The first one is anorexia nervosa. So this is characterized by significant low weight that can either be significant weight loss, or in some children and teens, failure to make expected weight gains that we would expect to see with growth. There's an intense fear of gaining weight, and also disturbance in how one perceives their body. So perceiving themselves to be overweight, obese, despite being very emaciated. It is more common in females, however, it does occur in males. And it's slightly more common in adolescents and in younger adolescents compared to adulthood, versus, as we'll see in bulimia and binge eating disorder, that tends to affect slightly older teens and young adults. The medical complications with anorexia are severe. In addition to the ones I mentioned earlier of the bradycardia, the low heart rate, low blood pressure, low core body temperature. They're also at very high risk for osteoporosis. And I have seen osteoporosis and the slightly less severe osteopenia in patients as young as 17 and 18. So it's not something that only happens when you've been struggling with this for decades. Anorexia is also the most difficult to treat. It is shown to be more irretractable than the other eating disorders. That being said, we do have treatments that are effective. And again, the earlier we can intervene, the better. Anorexia does have the highest mortality rate. Even when we separate the other eating disorders, anorexia on its own has an extremely high mortality rate. Bulimia nervosa is another one of the more common eating disorders. It is characterized by recurrent episodes of binge eating that are typically particularly preceded by episodes of extremely severe restriction. That then it is actually the restriction that leads to the loss of control with the eating, and they then engage in compensatory measures such as vomiting, laxative abuse, or compensatory exercise and restrict and try to get rid of the food. Similarly to AN, their way that they evaluate themselves is overly influenced by their shape and weight. But individuals with bulimia tend to be average to or slightly overweight, versus if someone is engaging in binging and purging behaviors, but is also extremely underweight, we would give them a diagnosis of anorexia binge purge subtype. So that's just one thing to note, that diagnosis of anorexia will override a diagnosis of a different eating disorder. Slightly more common than anorexia. As I mentioned before, we tend to see this as more common in older adolescents and in young adults, but again, happens across the age spectrum. Bulimia has a slightly better diagnosis than anorexia. It tends to respond to treatment better, and we have more treatments that we know work for bulimia. That being said, because individuals with bulimia don't typically have the outward signs of illness that someone with anorexia might, it can be harder to detect. A lot of these individuals really suffer in silence for a long time without getting help. Binge eating disorder is another disorder that, fortunately, with the most recent edition of our diagnostic manual, which categorizes mental illnesses, binge eating disorder was finally given its own diagnosis, which has really helped with insurance coverage for treatment. Binge eating disorder is characterized by frequent binge eating episodes. And I want to take a moment to clarify what a binge is and how that differs from typical overeating that all of us engage in from time to time. So a binge does involve eating an objectively large amount of food in a condensed period of time, around 2 hours, but it involves a loss of control, which is really the key piece that differs a binge from overeating that we all do, say, on Thanksgiving when we're together with our families, or when we are really, really hungry and we just sit down to eat a really large meal because we, haven't eaten in several hours. This loss of control and this feeling of not being able to stop, of not wanting to stop, of sometimes even dissociating during that period is what makes a binge a binge. And binge eating disorder also includes things such as eating more rapidly than normal, eating past the point of being full, and really this significant distress about the binge episode, feeling a lot of shame and guilt, wanting to eat in secret, wanting to hide these behaviors. Just one thing to note, I'm not going to get too into this because of time, but we oftentimes see binge eating disorder onset after people have gone through weight loss programs. So it is not that binge eating is what is leading to being overweight. It is the dieting and restriction that is what is perpetuating the binge and keeping that in place. I'm going to briefly talk about ARFID, avoidant restrictive food intake disorder. This is what we also know as extreme picky eating. We tend to see this more often in younger children. This is where there is a restriction of intake and highly selective eating, but it's not driven by a body image disturbance, but rather it's driven by oftentimes sensory issues around texture, smell, taste, or sometimes anxiety. For example, fear of negative consequences, becoming sick, vomiting, choking on food. It is something that we also have very, very good treatments for in younger kids, most often involving families. Finally, this category, other specified feed and eating disorder, this used to be known as eating disorder not otherwise specified, is really this category of patients who are either presenting with an atypical case or have features similar to anorexia or bulimia, but don't quite meet the clinical threshold. It's a very large portion of eating disorder diagnoses, and our research data really suggests that these sub-threshold cases don't differ significantly from clinical cases, and we're going to treat them the same way as we would someone who's meeting meaningful criteria for anorexia or bulimia. So some treatment considerations. I'm going to sound like a broken record. I'm going to keep saying it. A specialized treatment for eating disorders is essential. We really want to get individuals suffering with these illnesses to providers who are specially trained in this. And as mentioned, this oftentimes includes a team, a multidisciplinary team, including psychologists, psychiatrists, therapists, along with medical providers and dietitians. Briefly, the therapies that we do, I've mentioned family-based therapy. This is the therapy that has the most evidence for adolescent anorexia. It has very, very good outcomes, and it really puts the family in the role of supporting the adolescent and really sees food as medicine. And then works on handing that independence back over to the teen and getting the teen on with their life. There's also some evidence that FBT is effective for bulimia, adolescent bulimia as well. And we also see be really, really effective with ARFID. There's some evidence that some modified versions of FBT for young adults with AN has also been effective. That does involve a lot more sort of buy-in and participation from the individual because of that their developmental status. Cognitive behavioral therapy, or CBT, is really our gold standard of treatment for bulimia and for binge eating disorder. We have a lot of data showing that this is a very, very effective intervention. It focuses initially on supporting individuals with behavior change, sort of regulating eating to reduce binging and purging, and then helping them understand how their that over-evaluation of shape and weight is keeping these behaviors in place and helping them think more about what kind of life do they want to be living, what's really important, and helping them make changes and steps towards that. Acceptance and commitment therapy is a newer therapy that shares some similarities with CBT. And it focuses a lot on helping individuals think about what their values are, what is ultimately most important to them, what makes life meaningful, and how can they accept thoughts and feelings, no matter how distressing, while continuing to move towards those values and those goals. Adolescent focused psychotherapy is an individual therapy. It is based in psychodynamic theories, and it does have some evidence for adolescent anorexia. It's the only individual treatment we have really seen be effective for adolescents with anorexia. And then finally, interpersonal psychotherapy has some evidence for anorexia, bulimia, and binge eating disorder. And this is where we sort of look at interpersonal relationships and processes and how these might be related to the perpetuation of the eating disorder. And then finally, medication has been shown to be helpful for managing some of those co-occurring psychiatric diagnoses, such as anxiety and depression. And there's some evidence that it may help reduce binge episodes. We do not see medication be very effective for treating anorexia, whether that's with adolescents or with adults. So a little bit about what to look for if you are concerned about someone, whether as a provider, a client that you're working with, or if it's a friend or family member. Things that none of these things guarantee that someone has an eating disorder, but they're things that if you're seeing several of these might raise some red flags and maybe a good indication that it would be wise to have an open conversation with that person. So things such as throwing away food or skipping meals. This can also look like drinking large amounts of diet soda in place of meals, making irrational food choices. So this can look like avoiding high fat foods, avoiding higher whole categories of foods, or eating kind of excessive amounts of fat-free foods. A secrecy around eating. So someone who tends to avoid eating in front of others, tends to prefer eating alone. Parents, you might find hidden wrappers or containers in one's room. These are just things to be noticing and to be concerned about. Frequent trips to the bathroom, especially after meals, or could also be frequent tardiness to class or to appointments. Frequent attempts at dieting. So someone is sort of frequently engaging in dieting behaviors. It is possible that they may be struggling with something even a bit more serious. We know that dieting is actually a huge trigger to the development of an eating disorder. Excessive exercise. I know that this can be difficult to assess, especially for individuals who may participate in sports. Something that can help kind of differentiate is sort of excessive exercise becomes a problem when it becomes compulsive and driven. It's not something that someone is doing because they enjoy it. They may start exercising outside of, for example, regular sports practices, exercising at times that are unsafe, for example, late at night or when it's stormy out. The feeling of like they have to do it is sort of a sign that exercise is becoming a problem. Also, we see sometimes personality and mood traits. So increased irritability, depression, and social withdrawal are very common with eating disorders. Obviously, excessive weight loss. Now, we don't always know. There are other reasons that people may lose a lot of weight, but this is something to just note and be concerned about. And finally, frequent talking about food, weight, body image is something that, again, when combined with some of these other things, may raise some concern. So what to do? So first of all, I want to really emphasize, remember that the eating disorders are not choices. They are signs that someone is having difficulty coping in their life and is in need of help. So as much as possible, coming from a compassionate, non-judgmental stance and a place of curiosity. You're coming to this person out of care and concern and wanting to learn. Oftentimes starting with a very open discussion and stating specifically the things that you have observed. I've noticed you've been losing weight and I'm wondering what might be going on. I noticed you haven't eaten lunch the last several days and I'm just wondering, if you're okay. And then really being open and receptive to whatever they may share. If this is the first time that this subject has been broached with them, it may be that they are not ready to talk about it. You may find the person shutting down, but you've let them know that you are there and that you care. And when you then leave the conversation open, let them know that they can come back to you, that you are willing to talk about this when they are ready, and go a long way in creating that space for someone to share something that they may want to, but may be very, very terrified to discuss. When we are dealing with clients or individuals who are minors, there are certain points where we need to involve parents. If you believe that there is purging behavior or severe restriction, these things, because of their physical risk, it's really essential that we bring parents into the picture. And so, again, expressing your concerns to the child in that open and caring way, and letting them know how important their health and well-being is, and the need to bring parents in to support the picture. And then finding when the person is ready, providing resources for that specialized care, getting them connected to organizations that can help them get connected to treatment. So summary, eating disorders are not choices. They are serious psychiatric illnesses that need early intervention. They have serious physical complications that does include death. And unfortunately, many people with eating disorders do not receive treatment, despite the fact that we do have treatments and people do get better. And again, we just know that specialized treatment and early intervention are key. So there's just a couple of local and national resources. Janice's organization, Eating Disorder Resource Center, is a fantastic resource. Our clinic on Quarry Road, and then a couple of national organizations, Academy of Eating Disorders and the National Eating Disorders Association. I think I did it in time.
That's great. Thank you, Professor Colborn. That was great. And I know a lot of folks have asked, again, making the slide deck available. And
yeah, I'm happy to do that.
That'd be great. Thank you very much. That was excellent. And I think it was a perfect lead in to our next two panelists. Amia, it's good to see you again. It's been a while.
Yeah.
I don't know if you remember, probably not, but you spoke at a Lucille Packard. You were at a Lucille Packard conference, and you met my daughter, and she's going into the field. So
oh, amazing!
Yeah. So thank you. I think it worked. Your advice helped.
Oh, thank you for
so
saying
thank
that.
you. So anyway, but I just wanted to, let me just introduce you. You're in the final year of the doctoral program at the UC Berkeley School of Public Health. Go Bears, and with a focus on maternal and child adolescent health. You earned your Master of Science in Community Health and Prevention Research from Stanford University School of Medicine, where you conducted research on the mental health needs and concerns of Asian American adolescents and parents. In 2019, Amia was nominated by the Santa Clara County Behavioral Health Department for a Community Hero Award for her policy and advocacy work on adolescent mental health. And just this past December, Amia also qualified for the Boston Marathon. That's not too shabby. Little bit of work there. So great job. And it's great to see you again. Thank you for coming to share your story.
Thank you. Thank you for that introduction. Good afternoon. My name is Amia. As just shared, I'm a fourth year in the Doctor of Public Health program at UC Berkeley, where my research focuses on adolescent mental health and well-being. And I'm very excited to be in community with you all today. Being able to speak with you today as an advocate has been a long journey that started with my own personal experience with disordered eating in high school. I want to share a trigger warning that I will be mentioning my experience of eating disorders, depression, and suicidal ideation. So please take whatever you need to prioritize your own mental health during this conversation. So sports and running have always been a major part of my identity. Unfortunately, as a first year in high school, I developed the mindset that the leaner I was, the faster I would be. Throughout my adolescence, I experienced anorexia. I was very restrictive with my eating. So the amount of calories I would consume, the types of food, I would throw away food and skip meals. I did not like eating in front of others, which was very isolating socially. And I experienced the excessive exercising that Dr. Colborn was just sharing about. By my senior year, I was one of the fastest 400-meter runners in the state of Washington. However, the pressure I put on myself in school and sports contributed to my major depressive disorder and suicidal ideation throughout high school. No one knew that my biggest opponent wasn't on the track, but it was in my own head. As the daughter of a Filipina immigrant, the biggest barrier to getting professional help and treatment was the stigma of having an eating disorder and other mental health problems, as well as the cultural barriers to accessing treatment. By the time I got to college, I was hospitalized 7 times for not fueling my body adequately. I was a Division I athlete at Santa Clara University, and fortunately, I had coaches and teammates who wanted to see me healthy and supported me to get professional help, which included seeing a therapist, nutritionist, and receiving nutrition counseling. They brought it up with me and told me that they cared about me and that they wanted to see me get help. While a student at Santa Clara, I was first connected with the Eating Disorder Resource Center, one of today's sponsors, where I worked as an administrative assistant, connecting youth and adults in my community to resources and organizing educational workshops at schools and workplaces. That was 9 years ago, and after years of being a volunteer, this past year I joined as a board member. The mission of EDRC is to increase awareness and understanding of eating disorders for the general public and for health professionals to promote early diagnosis, effective treatment, and recovery, and to advocate for mental health legislation. We collaborate with other organizations such as the National Alliance on Mental Illness, or NAMI, in our effort to bring the needed attention to eating disorders. EDRC offers a comprehensive online resource directory and facilitates monthly support groups for individuals and their families and friends. And we're here to respond to calls and emails from patients, family members, clinics, and healthcare professionals requesting support and information. And that can be information around treatment options and help with navigating the healthcare and insurance systems. Lastly, we offer an education and outreach program on the early detection and intervention of eating disorders. I continued my advocacy at the community level as a local title holder in the Miss America organization. What feels like another lifetime ago, I was Miss Silicon Valley 2018, and my personal platform was mental health advocacy, and I partnered with NAMI, and I spoke at high schools and universities throughout the Silicon Valley, talking to students about my story and offering educational resources for eating disorders and mental health. One of the best pieces of advice that I've been given to this day was be the person that you needed when you were younger. And that is at the core of the advocacy work that I've done around mental health, thinking about my high school self and how I needed someone to talk to, and I needed to be educated on resources available. Within this community health experience, I continued my higher education at Stanford University in the School of Medicine, where I earned my Master's of Science in Community Health and Prevention Research. And my research was at the Stanford Center for Youth Mental Health and Wellbeing, where I conducted qualitative research focused on the mental health needs and concerns of Asian American adolescents and parents in Palo Alto. I led focus groups to understand the youth perceptions around mental health, the accessibility of support services, and potential community approaches. Participants identified stigma against mental health as a significant barrier to open communication between family members, as well as to accessing mental health services. Parents also identified difficulty in discussing emotional topics and specifically wanted to develop skills to better communicate with their youth. So in response to these findings, I helped design a workshop aimed at improving communication strategies around the topic of mental health. And my personal experience with mental health and trouble seeking mental health support services as an Asian American youth motivated my research with this population. And I think this work exemplifies the importance of mental health advocacy, specifically for BIPOC, which stands for Black, Indigenous, and People of Color, communities specifically. Since the pandemic, I have represented EDRC virtually on Capitol Hill at the Eating Disorders Coalition annual advocacy day as an advocate to educate members of Congress and push for important policy goals. In 2020 and 2021, I advocated for the Nutrition Care Act, which allowed Americans on Medicare to receive medical nutrition therapy services at the outpatient level for eating disorders. And additionally, the Healthcare at Home and Telemental Health Improvement Acts required commercial and ACA plans to cover telehealth services as they would for in-person services during the pandemic. And this ensured safeguards during the pandemic so that folks could receive and provide mental health care in person or via telehealth and continue eating disorder care and recovery, which was really important during that time. During COVID, there was a significant impact with increases in anorexia, bulimia, and binge eating. Last year, I met with the congressional offices for California state representatives to gain support for policy, and we successfully advocated for the Kids Online Safety Act, which addresses the mental health harms by social media platform algorithms by one, enhancing parental and youth controls on platforms to further empower the user's experience, and two, establishing a research data bank to utilize social media company data to study the impact of social media on mental health, which is a researched area, but it's great that there would be an opportunity to collect more on the impact of social media on mental health. Lastly, the Anna Weston Legacy Act reauthorized the Center of Excellence for Eating Disorders and their training of primary care providers, and expanded primary care eating disorder screening protocols. And something that stood out to me around that act was there was specific protocols for underrepresented communities, such as racially diverse and LGBTQ communities. I don't think that my 14-year-old self would believe that my mental health struggles would motivate my education career now, 15 years later. This spring, I'll graduate with my doctorate in public health from UC Berkeley, where my research has me working directly with youth to address mental health and other health equity issues in San Francisco Unified School District. And I plan to be a leader in this field and advocate for policy that directly improves access to healthcare for our underrepresented communities. The key things that I hope that you take away from our discussion today are that, one, as someone who has lived with disordered eating, folks with this life experience are not defined by our mental health struggles. And I just hope I can be an example of someone who chooses to be an advocate in this work and use my lived experience to help others who might be navigating a similar experience. Second, I hope you've learned about the Eating Disorder Resource Center as a resource for your work and the individuals and communities that you serve. And lastly, I hope that you heard about the community level work that the EDRC does, and also hear the importance of policy in making system level changes to connect individuals and communities to services and resources. So I would like to conclude by thanking David and Momentum Health for organizing this event and giving us this opportunity to raise awareness. And also want to thank the other speakers, Dr. Colborn and Paraag, and I'm excited to be listening and learning from you both.
Thank you, Amia. Yeah, you were amazing in 2018. Here we are 5 years later. Man, you are just magnitude geometrically
Thank you.
bigger, badder. Wow, that was awesome. Thank you. Finally, and I have to say this because it's in my notes, and I feel like I have to say it because in the end zone we have Paraag Marathe. I'm sorry, I had to actually say that line. And Paraag is the president of the 49ers Enterprises and executive vice president of football operations for the San Francisco 49ers. He's got so many things he's involved in, but I would direct folks to go onto YouTube and search Paraag, because there are videos there that I think are related specifically to the topic at hand. And they're very personal, and I think Paraag is going to talk about it in a second. Additionally, Paraag is a faculty member at Stanford's Graduate School of Business, where he's a lecturer in management and co-teaches MBA courses on negotiation dynamics in sports, entertainment, and media. Also a graduate of said program, but also in the interest of the theme of Stanford and Cal today, was also an undergrad, also graduate of Cal as well. So Stanford Business and Cal. In 1996, Paraag was watching the movie Jerry Maguire and had initially aspired to become a sports agent. He didn't end up becoming an agent, but did become the 49ers chief negotiator, communicating with many sports agents. So again, thank you for joining us today, Paraag. We appreciate you taking the time today.
Of course, yeah, I'm happy to be here. So I guess for all of you on the chat, I just wanted to share a little bit of my personal story, in really just the hopes that maybe I can inspire somebody out there to reflect on their own situation and maybe help someone that they care about. So let's see, where do I begin? I grew up, I lost my older sister, Shilpa, to anorexia in 2005. And she had been suffering from an eating disorder for a number of years, and had, mental health issues for a while. And, we grew up right here in Saratoga in a very traditional immigrant family, first generation immigrant family. My father was an engineer. My mom was a homemaker, and everything was focused in a traditional Indian American family. Everything was focused on just go get good grades. Nothing else really matters. Just go get good grades and put yourself in good school or whatever that might be. so that was our charter. That was all we had to do. And there really wasn't anything else. And certainly there was no compassion for those with mental health issues, because mental health wasn't a thing. You either do or do not. There's no such thing as suffering from emotional distress of any kind. You just keep moving on. And so, from an early age, we were sort of conditioned to just compartmentalize if things got challenging or difficult for us. Unfortunately, my sister succumbed to it, and I persevered. But I did it in a way because I became a master compartmentalizer. And so when my sister was ill for probably really ill for the last 8-9 years, and I remember that she was a great student. She went to UCLA for law school, finished top of her class, and got a bunch of interviews from all the top law firms. But the moment anyone saw her in person, she was immediately failed because of how emaciated she was and how she looked. And so that was the beginning of me just feeling very angry about it, but didn't really do anything about it. And so, so my sister lived at home for a while, and she passed away in 2005. And I thought I was doing a really nice job of compartmentalizing because I just blocked it out of my mind. I had a lot of feelings, resentment towards my parents for not addressing the issue, resentment about myself for disguising my own embarrassment and shame as anger towards other people. So feeling like my sister, all she wanted was companionship. And as Danielle talked about, someone who's open, or not someone who's non-judgmental, just being kind of compassionate. That's all she wanted, and I couldn't give that to her because I wouldn't want to go out to the movies with her, even though that's all she wanted, because I would convince myself it was because other people would it would anger me to see how other people looked at her. Well, it took me a lot of years to realize that that's not really the case. It was really it was embarrassing for me to be seen with her. And I thought it was a reflection on me that people saw me with someone that looked like she did. And what does it say about me? So there's a lot of things like that I just kind of bottled up for a number of years. And at the time, my professional career was growing. And I realized, all right, as difficult as things are personally, I was just going to define myself by what I did, not by who I love and who loves me. And that was backwards. And, I spent a lot of years just thinking, all right, like this is how I'm going to get my life's definition, by growing my career and just focusing on that, and not about love and compassion and honesty. And it took me until 2011 probably where I realized, wow, this is a really big mistake, because, pardon my language, but none of that other shit matters. All that matters is who you love and who loves you and who you want to spend time with, and everything else is noise. And so I realized the position I was in, because in my culture, in my profession, in my gender, there's mental health and eating disorders. It's not even a real thing. It's fiction. And so here I was as a Indian American man in the macho sports industry. And I realized if I just would talk more about it and be more of an advocate for talking about eating disorders and how it's okay to hurt, and it's okay to acknowledge that you hurt or that you love someone who hurts, that I probably might get a few more mentions than not, versus anybody else who might talk about it. And so that's when I guess went on my own, I don't want to call it a crusade, but I just decided I have nothing to hide anymore. And I want to talk about it as much as I can, because if just someone out there can hear my voice and is maybe in the same position that I was from, 1999 through 2011, where I just blocked it out and pretended it didn't exist, then maybe I can help them. I remember I reluctantly agreed to do a piece in the New York Times with somebody who wanted to interview me about this. It was 2010 maybe, and it was probably the first time I actually came out and started talking about this. And And the thing that resonated with me the most is there was a gentleman who was on a flight from North Carolina to New York, or the other way around, and it was in the paper copy of the New York Times, and was reading it, and he wrote me a note the next day, and said that he read that, and he had a sister who was suffering from an eating disorder, and he also was consumed by just figuring out how to compartmentalize. And he got off that airplane, didn't make his flight, and went over to his sister's house. And I honestly, I lost touch, and I don't know what happened, but that's I don't know, that kind of made my decade, because it was just something that I wish someone had done that for me during that time. Now, nobody could have, because because I felt so much shame and embarrassment and so many things, that I probably wasn't ready to hear that. But, you know, here I am today, at least, being very comfortable talking about it, because it's very real, and people need help in this world. And you know, it's for parents, for immigrant, certainly, you know, Asian American or Indian American in particular, because that's the world that I live in, or academically focused families. You just don't really think about anything that takes you off the track that you want to be on, or someone else is prescribing for you. And so, but you know, these things are real, and a lot of times someone just wants someone to talk to, companionship and compassion. That's all. And then from there, other things can sprout that can really help someone. And it's very important to understand that the difference between sympathy and empathy, because you know, you can feel sorry for someone, whether it's a friend or something like that. But unless you know, take a minute to understand what it's like to walk in their shoes. I think Danielle said it earlier too. It's not a choice. Someone with an eating disorder, anorexia, or depression, it's not a choice. And they certainly hope and wish that they were not in that position. And so it's just, you know, the empathy to understand that, and understand that they just want someone to talk to. I mean, there's so many things that I wish I could have done differently. And it's not an excuse for me that I was just a young kid at the time, not understanding, because, you know, even if I was 30 or 40 at the time, I would have been the same, because I just had so many other things that I was just making it about me. So that's it. I'm really not sure what else I have to say, other than I just wanted to, you know, say that it's okay to talk about, and these things are real.
Thank you, Paraag. You know, I had the same reaction as when I watched you on YouTube, some of your previous, you know, both times they've made me cry, talking about your sister. And I want to actually just sort of hold, and I want to make sure that you know, that we all remember and think of your sister, Shilpa. I want to make sure we say her name. And, you know, for everyone who, you know, we've lost. You know, again, I thank you. I thank all three of you for coming in today and being a part of the panel. We have, you know, again, the rawness of people telling, you know, their stories and trying to make it better for others. You know, attaching what we know to be best practice, and, you know, effective treatments, and getting people to help earlier than later. Having those courageous discussions inside our families, trying to help that happen, man. That was, you know, in our quick webinar today, that was the hope. So before we go, we just want to get folks just to take the poll. We want to just check to see how you heard about this, because we have other topics and other important webinars that we're working on right now that we want to get out and get to folks. We want to see, you know, how we were able to connect with so many people. So please, if you take the poll, that'd be great. We have been answering the questions. Thank you, Professor Colborn, for answering questions in the Q&A. if, you know, Paraag or Amia, if you want to also, if there's anything in there. Yeah, these are good questions. Again, Medi-Cal covering treatment, eating disorder treatment, adolescents, again, who at this point may not want to recover. How do we, you know, again, intervene? How do we talk to them? And again, best treatments. So they're in the Q&A. Again, thank you for answering those. And all right, so slide deck, Dr. Colborn's slide deck. We will, I'm told that Cassia, we will make that available. And we probably make it available to everybody who actually registered for today. And okay, thank you. Yeah, I got confirmation from Cassia. We will send out the slide deck to everybody who registered today. All right. And again, just thank yous to, I appreciate in the chat, just the thank yous to our panelists and following up with them on questions and any other, please email us at Momentum if you have other follow-ups and other questions that we can actually then follow up with the panelists and or other resources. Or Janice, the resource, the biggest resource of all, Janice Bremis. So, okay, I think we are close to being out of time. We're 2 minutes out, and thank you, Danielle. Thank you, Amia. Thank you, Paraag. I have a feeling that the information you shared today really, hopefully, will help save lives today immediately. So, so thank you. All right. Well, very good. Thank you, Cassia. Thank you, Janice. Thank you, Kanika, and thank you all for joining us today. Everybody have a good afternoon, and look for our next webinar. Thank you all.